on behalf of the psych department to suicidality and self-harm. So I think when we hear the S word, and in this context, I'm not talking about swear words, but suicidality, it sends panic, whether that be in your role as a parent or a teacher or a friend or even a healthcare provider. It makes us really scared when we think of suicidality, because we obviously understand the implications. So today I just want to kind of speak practically about suicidality, raise awareness about kind of warning signs, things to look out for, and we'll speak more to kind of what to do if a child is presenting with self-harm and suicidality. So I think first off, kind of what do I mean when I'm speaking about suicidality? Well, suicidality includes, suicidal thoughts and feelings and suicide attempts. Suicidal thoughts and feelings, they're not uncommon. Numerous people experience suicidal thoughts throughout their lifetime, and these vary in severity from these kind of fleeting thoughts and sometimes very impulsive acts to quite a fixed preoccupation with death and detailed planning. Not everyone that has suicidal thoughts goes on to attempt suicide. And I'm not saying this to kind of trivialize suicidality. We must always take suicidality very seriously. But I'm saying this to demonstrate that we can intervene and we can assist people in dealing with their suicidal thoughts and help them find healthy coping strategies. So in terms of kind of risk factors or predictors, although these are kind of far from perfect, there are certain characteristics that are associated with an increased odds of children or teenagers experiencing suicidality. So first off is child mental health. People that are experiencing depression or mental health challenges such as kind of bipolar, schizophrenia, or substance use, they have an increased risk of experiencing suicidal thoughts. Substance use often also increases the intensity of depressive symptoms, impulsivity. It impairs our judgments, which often can lead to suicide attempts. Family mental health is also a predictive factor. So a family history of mental illness, particularly depression or substance use, is a risk factor. There seems to be some kind of genetic predisposition, which may be exacerbated when the child or teenager is stressed. This is particularly so, if a child has witnessed or has loved ones who has attempted suicide. Then importantly is kind of the situational crises, the life stresses, the traumatic death of a loved one, physical, sexual abuse, family violence, family dysfunction, among very many other kind of crisis situations may exacerbate the child's potentiality of attempting suicide. And then environmental risks. So kind of an unsafe home environment where, a child may have access to firearms or harmful substances. That's also a risk factor. The child's also at risk if they have engaged in prior suicidal behavior, because this kind of shows that they don't have healthy coping strategies when they're struggling, and so they could possibly engage in these behaviors again. So how do you know? How do you know if a child is experiencing suicidality? So I think when we're engaging with warning signs, I think as a general rule, any kind of drastic change in a child's behavior, or a change in functioning at school with peers or at home, I think all of these things are quite a clear tell that something's not right, and the child needs additional support. When a child is quite seriously considering suicide, you'll also, you'll see the suicide threats kind of in the form of direct statements like I'm going to kill myself, or indirect statements, I wish I could just fall asleep and never wake up again. Suicidal notes and plans, in today's kind of age as well, these are not always likely to be pen and paper, but you may see on social media platforms suicidal engagements. Making kind of final arrangements. So the child may make funeral arrangements, they might, write a will, they might be giving away prized possessions. And in this, you might even see a positive change in the child's behavior because they received some kind of closure in their decision. And they might have great guilt about what they're going to do. So their behavior changes, and not necessarily in a negative way. there's a preoccupation with death. So with children, we often see this play out in play. So we'll see storylines and we'll see narratives often relating to self-harm. Dreams are as well a clear tell. And statements of hopelessness, no sense of purpose. And then, as I've said previously, kind of changes in behavior, appearance, thoughts. There might be depressive symptoms, withdrawal, sudden mood changes. We might see aggressive tendencies. So yeah, those are generally things to look out for. And then I guess if we're speaking to risk factors, we also should engage with protective factors. So protective factors would include, having a safe, supporting family environment, peer relationships, and to have these relationships characterized by kind of open, non-judgmental communication. A feeling of kind of connectedness with certain environments is also very protective, whether this be at school or within a certain community group, maybe a youth group or a sporting team. Cultural and religious beliefs that promote kind of healthy living and encourage this belief of life as purposeful are also very useful. And then good coping and problem solving skills. So good kind of conflict resolution. This is a child that when they're stressed, they are able to engage with others. And when they're feeling stressed, they will play sport or they'll journal or whatever it is that soothes them, but soothes them in a healthy, kind of non-harmful way. And then obviously if we're saying kind of a sense of purposeness, low self-esteem is a risk factor for suicide, then the opposite, kind of general life satisfaction, good self-esteem and a sense of purpose would be protective or a source of resilience. And then finally, kind of easy access to and knowledge about medical and mental health resources, so that if a child is, feeling suicidal, they are aware of the capacity for help and they have access to be able to reach out for help. So more than this, I just want us to deal a little bit with kind of myths or incorrect assumptions surrounding suicidality. Because it's only really in abolishing these that we can properly understand and empathize with children who are feeling suicidal. So one that often comes up is that talking about suicide or asking someone if they feel suicidal will encourage suicide attempts. Asking a child directly about suicide will not increase their risk or, kind of plant the idea. But it's more likely to create an opportunity to offer support and to let them know that you care enough to have the conversation. If a child is talking about any level of stress, asking them how they're feeling and if they are having suicidal thoughts in an open, non-judgmental or panicked manner, that's important. That's very useful. Avoidance doesn't benefit anyone in this circumstance. Another myth is that young people thinking about suicide are depressed or mentally ill. So 1 in 5 people have thoughts about suicide at some time in their life. So, although someone thinking about suicide is likely to be extremely unhappy and they could very well be classified as having a mood disorder such as depression, it doesn't necessarily have to be present for a person to attempt or die by suicide. We often pathologize the child when they're responding quite normally to an extremely abnormal situation in their lives. And we need to be empathetic to this and not kind of place them in a sick role, but deal with where they're at. Another one is that people who threaten suicide are just kind of seeking attention. It's difficult and it's one that we always need to take very seriously. Just by virtue of a child or adolescent engaging with notions of suicide, it demonstrates that they're in distress and they're struggling to cope and that they're needing something from their current environment which they're not getting and needs to change. So, parents often feel like their child is being dramatic, but just the need or just by virtue of them feeling that they need to go to these depths to receive support is saying something. It's saying, we've got a child that's not coping. So it's very important that our primary action is to assist first rather than criticize. Another one that parents often feel is that if they do something about the suicidal thoughts that the child is feeling, if they seek interventions or if they tell someone that the child's going to be really angry with them and is going to resent them. There's this fear that we're somehow going to make the situation worse. But for most children or adolescents considering suicide, it's genuinely a relief to have someone to feel, that they've got someone that genuinely cares about them, and that they're able to share this emotional burden. And often, research shows that when questioned sometimes later, the vast majority of children and adolescents feel very grateful that an intervention was conducted. So encourage therapy or even a hospital admission if you do feel that your child is at risk. This is very much a situation where we rather want to be safe than sorry. And then finally, this notion that, the only kind of effective intervention for a child that's feeling suicidal or who has attempted a non-fatal suicide attempt is a psychotherapist or a psychiatrist. And yeah, 100%, psychotherapy and psychiatric intervention is, the recommended treatment for a child that has attempted or is thinking about suicide. But all people that are in the child's network can help them by way of, providing support, by giving them a safe space, by encouraging healthy coping. And it's when we involve kind of all of these systems that we are benefiting the child the most, and we're giving them the most support that they can receive. I also think it's important to note here, after a non-fatal suicide attempt, so a child has attempted suicide, but they haven't died by the suicide. Psychotherapeutic treatment is highly effective at this point. And it's because kind of after a suicide attempt, a child is feeling quite shameful, quite guilty, and it's when they are most motivated to engage in change behaviors. But it should also be noted that this is often when children don't continue with treatment. So once they get discharged from the hospital, caregivers often don't bring them back to be seen as an outpatient because they feel like, no, their child regrets it now, everything's okay. And it's in this time that we very, very much need to work with the child so that we can, provide them with good coping mechanisms, good strategies, so that in the future, if there is a situation again where the child is feeling really overwhelmed, really stressed, very depressed, that they have the tools to soothe and to not then engage in suicidal behaviors again. So I think that's really, for me, all I wanted to encapsulate in terms of suicidality. I'm going to pass on to my colleague Will, and he's going to engage with notions of self-harm and what to do.
My next slide looks at what happens, how do the individuals, how do children self-harm, how do they self-harm actually. And before even I actually go there, I'll just to touch base on the signs that we actually have to be aware of in our kids that will give us just an indication that possibly that our child is struggling and that they might end up self-harming. This is expressing of suicidal thoughts, continuously talking about death. I want to die, I don't want to live, I don't understand why I'm still here. There's no reason there's no purpose in life. We look at physical symptoms. This is basically most of the time they're struggling to sleep, hypersomnia or insomnia, sleeping less, changing eating habits, their weight. We're looking at things like withdrawal and isolation from family and friends. Also, something that is when we during a history taking that is very important is understanding family makeup. Is there family conflict and instability in that family that could also affect the child's presentation? Also, another thing that we can link to all these things is academic performances. Is there a sudden drop in the child's grades? And linked also to that is bullying. That is also very common in our society, in our schools. I think speaking of, there's been a lot of recent videos that I've been making that have gone viral of children being bullied at school and at the end of the day resulting in self-harm. I can't remember the name of the child exactly, but it was an incident that happened in Limpopo whereby the child was bullied a lot and at the end of the day she committed suicide. So that's a typical example of bullying and how it can go far, and that should, as soon as it's noted, it should be addressed. Persistent abuse of drugs or alcohol, and recent loss or close relationship through death or suicide. So, usually, what happens with children or individuals is that there's cutting, there's scratching, there's picking of scabs, burning, punching the self, inserting objects into body openings, bruising, and hair pulling. So you can see that it's extreme things that are just there definitely to cause harm to the self, and as a form of releasing whatever pain that the child is experiencing, they do their self harm. So, looking at and zooming into our South African context, I went through just was I like to get these two research, the recent research that was done in South Africa, where they explained the common ways of self-harming from kids and even grown-ups. Self-poisoning, which refers to drinking of these detergents, household detergents that are readily accessible. Bleach, your jig, your red poison. Red poisoning, your handy Andy, anything that one can think of or that might cause damage to one's body internally or externally. Because they are readily available, they use this. Again, another one is prescribed medication to the individual or any family members. Again, the accessibility, if it's accessible, they will make use of it. And also paracetamol, which is readily available over the counter. Another interesting study that was done also still in South Africa between 2006 and 2014. So here they collected data of children from the ages of 14 or 15 up until the ages of 30. So they just tried to check the reason or cause of death. And then they found that most of suicides that occurred via one hanging themselves, and the understanding or the reasoning that came about with this common way of self-harming, which is hanging yourself, is the fact that there's less planning to it if you think about it, and the fact that there is no bloodshed during this process. So that's why most people would resort to that. Next is we look at the risk factors. What are the risk factors that individuals can or should be aware of? It's the biological, social, and psychological. So you'll notice that I wrote that self-harm behavior can begin in early adolescence. So it's very rare that you get self-harm behavior in individuals that are less than that are below the adolescent stage. It does happen, but it's very rare. So biological changes, what happens is there's a lot of physical and physiological changes that are met with a confusion from an individual not understanding what's happening with them, especially if such conversations were not held with their parents or in that school. And even if they are held with their parents at that school, sometimes it comes with a lot of shame, it comes with a lot of expectations from one to say that comparison between the two in terms of getting into that new phase of your life, and also the expectations of those changes happening can also result into certain stresses, or it can also result into children experiencing distress if there's no changes happening, if I can put it like that. This is the opposite of their expectation. If now, let's say now a child is expecting that something should be happening with themselves, and they should be, I might take for example a female, that there should be breast changes, there should be menstrual cycle starting, and that doesn't happen. You can imagine how that affects certain fantasies that the child might have had. This is maybe based on having a child, them or themselves being a mother, and that can also affect and therefore bring this inadequacy feeling and that feeling of is there something wrong with me, and that anxiety. Secondly, we look at the social transition from childhood to adolescent, very difficult phase because it comes with a lot of responsibility, expectations in terms of how to behave, uh, who to go with you. And at that point in time, there's this identity versus role confusion. At this phase, an individual is trying to find themselves and is faced with all these possibilities in life that they have to choose from, and accessibility to things, to drugs, to alcohol, and as a result, substance abuse, and then one acting out of not a sober mind and end up having self harm. Psychologically, one would experience this powerful, overwhelming feelings that one cannot able to digest or one cannot be able to control, especially if there's physical and emotional abuse, a history of physical and emotional abuse. You can imagine how difficult that can be for an individual getting into such a phase and not being able to comprehend or understand certain emotions that they are feeling within themselves. So, what are the motives of self harm? This study indicated four of them. Interpersonal was the first one, which for me made sense. The struggle, and I think it focuses only on the social part of things, the struggle of identity, the struggle to belong, the struggle to wanting to be seen. I think most commonly what I've seen with adolescents is I have tried my best to please my friend. And you'd hear them saying this: I've tried my best to please him, I've tried my best to please her, but nothing comes out of my family, nothing comes out of her. And so there's this need to belong, but they seem not to be in that position, or rather, the system or that they find themselves in is not allowing or for them to belong. So it is an interpersonal issues or relatedness. Financial concern again speaks to accessibility of things. You can imagine as an adolescent, you're going into a space where there's certain things that is expected of you in terms of materialistic things to have, and not of a sudden, because of the fact that you, not all of a sudden, but because of the socio-economic status, you find yourself not being able to afford that, and that can cause a lot of frustration. And other patients also mentioned that the fact that they don't have tertiary or education, they reported academic concerns as one of the self-harm because of failure, feeling that they've failed themselves, they are not able to reach certain goals in their life, and the fact, and therefore they won't be able to be or bring their dreams into a reality. And I can, this makes me think of the recent protest, the Fees Must Fall protest, and I can imagine how many people, how many individuals were affected by that, and that led to them to having self-harming because of feeling as failures. Patients who reported psychiatric illnesses were also seen as noted as motives for self-harm. I'll get into that, which actually brings me to my next slide, where these group of people, or this group of patients, will be actually placed in under the psychosis category, where usually they'll be diagnosed with schizophrenia, depending if they meet the criteria or not. But usually at that point in time, or whether or when they self-harm, it is when the person has either dissociated and is not able to understand what's happening in themselves. It's not in the present. There's fragmented thinking that happens with people who are experiencing psychosis. So self-harm is a symptom. Self-harm is a symptom of these four categories of diagnosis. Borderline personality, as you could have noted actually in my last slide, there's I think about all three or four or all two or three of the motives of self-harm actually linked to borderline personalities, where there's instability, interpersonal relationship, instability in affect, how one views themselves, their challenges with their identity, suicidal thoughts, the impulsivity. So they kind of meet the criteria for personality disorders, mainly borderline personality. And depressive disorders, we're looking into the mood of the mood, the affect of the patient, the impulsivity and the lack of interest in things. We're looking at the some of the signs I did mention in my second slide. We're looking at appetite, weight loss. We're looking at sleeping patterns that will eventually make the person fall into this criteria. So, what are the treatment plans for people with suicidality or self-harm? One thing that I want to know, just to make note of, is that usually self-harm is detected, or patterns of suicidality is detected by friends and family. So after detection of that, we're expecting that the child would obviously be brought to the hospital, and the child will either be treated as an outpatient or inpatient hospitalization, and then an assessment will be done by one of the mental health professionals. So mainly we be looking at, is this behavior affecting the child's relationship? Does it affect the child's health? Does it affect, is it life threatening? And then based on that assessment, the decision will be made whether the patient is fit for outpatient or an inpatient. Usually the preferred choice of treatment is a combination of both medication and therapy. Medication is there to address what I just spoke about in the previous slide, the disorder, because remember, self-harm is a symptom to those disorders. So it gives us an idea into where to look, into which criteria should we look in terms of diagnosis. And then depending on how the patient presents, whether depressive, whether OCD, whether psychosis, or whether there's any personality issues, we will treat. The medication will be given based on that, to treat, to manage that that disorder. And then therapy is also there to support and bring about certain skills. We're looking at addressing negative behaviors, because we believe that my thinking rather is that self-harm is, because it's self-inflicted, therefore there is definitely some negative beliefs about the self. And we're looking at stress tolerance, bringing about replacing unhealthy behavior with healthy behavior. This is, we're looking at in cases where there's just no interest in doing certain things that they were interested in, bringing that gradually back, introducing new things into the person's life. Regulation of emotions, because the reaction of self-harming is an impulsive decision. So understanding and being aware of one's emotions is very important in that stage. So bring about that mindfulness techniques, and most importantly, interpersonal skills, which is based on the research that I brought. That I showed on the slide. I think the previous slide is, we saw that interpersonal struggles were actually noted, or interpersonal issues were actually high, with 70%. So interpersonal skills, this is communication with the other, how the other communicates with you, understanding of yourself, communication with the other, and how you relate with other people. that's the focus of the treatment. So this is in case of an emergency. That's the first thing that one would basically do is try to address or try to attend to the wound, seek medical treatment if it's a severe situation. Try not to judge and criticize. This is very important because I can imagine that if it's a first time happening, it brings shock to the parents, it brings shock to whoever that just saw that and experienced that, and then sometimes our reactions are just there you'll basically shout at your child and saying, what is it, what are you doing, and shouting, why are you crazy, all those nasty or not so nice words to the child, and that it's kind of moving away from the actual cry of the child and not seeing what is it actually, or attending to what is the underlying issue here. How come is this person hurting themselves and still fine with that? And that's where actually you will start recognizing situations or feelings that might trigger the desire to injure themselves. Just keeping track of the child and understanding, or even getting information from them to say that what is happening, what is it that makes you feel this way, when do you feel this way, and this will also help you when the child is brought to the hospital to give clear information to the treating mental health professional. So self-admission at the nearest hospital. I think with that said, that brings us to the end of our presentation. Thank you very much for listening.